Many people suffer from a common, unpredictable, and severely disabling form of vertigo called benign paroxysmal positional vertigo, also known as BPPV. It was given this name in 1952 by Dixon Hallpike because the vertigo is positional, it is paroxysmal or brief, and it is benign, that is, not life-threatening. However, it may not seem so benign to those who have it. Victims may be severely incapacitated for weeks, months, or even years, and falls caused by vertigo could result in severe injury. It accounts for more than 20% of the cases of dizziness seen in clinical practice. Treatment in the past has been largely symptomatic through the use of anti-nausea medications. These, however, did not control the vertigo nor change the course of the disease. Other forms of treatment, such as vestibular habituation exercises, were poorly tolerated and did not address the disease process. Surgery, such as canal plugging, is rarely indicated and should be a last resort. A new mode of treatment, kanalit repositioning, also known as the Epley maneuvers, now offers a high success rate with low risk and low morbidity, while being extremely cost-effective. It is based on the latest concepts regarding the pathophysiologic mechanism of BPPV and impacts directly on the disease process. This procedure has achieved wide acceptance, with successful trials being reported from major medical centers such as Johns Hopkins, Massachusetts Eye and Ear, and the Mayo Clinic. Kanalit repositioning was developed by Dr. John Epley, neuro-otologist at the Portland Otologic Clinic in Portland, Oregon.
At first glance, kanalit repositioning would appear to be quite easy to grasp. However, in order to achieve a high success rate with this mode of treatment, one should have a thorough understanding of the clinical presentation and the pathophysiology of BPPV. This includes the theoretical concepts underlying the canalithiasis theory, because this was the basis for kanalit repositioning. The information contained in this video stems from my extensive research and clinical trials in the development of this non-invasive procedure.
The different sections of this video are titled on backgrounds like this so that you can easily scan to a particular section. In 1952, Dixon Hallpike thoroughly defined the clinical entity BPPV and described the following diagnostic test, which now bears their name. The patient is maneuvered from a sitting to a head-hanging position with the head turned 45 degrees to one side. Each side is tested separately. The diagnosis is made upon observing nystagmus with distinct characteristics. First, there is a latency period of several seconds before the onset of nystagmus. Second, the nystagmus is rotatory in character or torsional, with a 12 o'clock position beating toward the undermost ear. Third, it is transient or of short duration, seldom lasting over 20 seconds. When the patient is returned to upright, the nystagmus occurs again after a latent period, but is reversed. With one or more repetitions of the maneuver, the nystagmus response typically declines and may actually disappear. These are the classical characteristics of typical nystagmus of BPPV. Simultaneous with the occurrence of nystagmus, the patient inevitably experiences severe spinning vertigo. The mechanism of BPPV was long a subject of speculation. Early theories attributed it to central nervous system pathology. However, Dix and Hallpike demonstrated in 1952 that they could stop the vertigo attacks by surgically ablating that labyrinth, which is situated on the downward side, during a positive Dix-Hallpike test. This finding indicated that the mechanism was in the ear. In 1962, Dr. Harold Schucknecht proposed that the mechanism involved dense deposits attached to or impinging upon the cupula of the posterior semicircular canal. Although this cupulothiasis hypothesis, sometimes called the heavy cupula theory, had some basic flaws, it nevertheless became the conventional wisdom for decades. It was the basis for various treatment modalities which, not surprisingly, had limited success, and it is still erroneously cited in some recent textbooks. But, like the emperor's new clothes, it was only necessary to take a closer look to detect those flaws. First, Schucknecht held that in the Dix-Hallpike position, the cupula of the posterior canal was placed into an earth horizontal orientation, allowing the weighted cupula to deflect earthward. But in this position, the cupula would generate torsional nystagmus beating away from the undermost ear. This is just the opposite of what typically occurs with BPPV, in which the typical nystagmus beats towards the undermost ear. Second, a cupula deflected by gravity would remain deflected as long as the head position was maintained, and thus would generate a persistent nystagmus. This fact is illustrated by studies with ingestion of deuterium or heavy water. The deuterium enters the cupula first, and when the head is held in certain positions, the heavy cupula deflects downward. This generates nystagmus, which may persist for hours. In contrast, typical nystagmus does not persist when the head is held in the Dix-Hallpike position. Rather, it is transient. Dr. Epley noted these and other discrepancies in 1979. After further investigation, he concluded that the typical nystagmus of BPPV could not be caused by densities acting directly on the cupula. Rather, that all cases were due to densities actually moving freely in the long segment of the canal. These he called canaliths, which could either be displaced otoliths, precipitated particles, or layering of fluid. Dr. Epley's canalithiasis theory followed this scenario. With the head upright, the canaliths collect in the most dependent portion of the labyrinth, the posterior semicircular canal. Upon tilting the head back, as in the Dix-Hallpike test, the particles begin to gravitate. A particle falling through fluid immediately assumes terminal velocity, in which the downward pull of gravity is equaled by the resistance of the fluid and the buoyancy of the particle. Its terminal velocity remains constant with respect to the fluid. This tube contains fluid of high viscosity to simulate indolence. Note how the particles fall slowly at constant velocity. In a similar manner, the canaliths free fall through a portion of the canal at constant terminal velocity. These canaliths act collectively to create a hydrodynamic drag on the endolymph, similar to a leaky piston. This deflects the cupula like a small piston driving a large piston. According to Pascal's principle, a small force applied to a smaller piston is magnified when driving a larger piston in direct proportion to their cross-sectional areas. Thus, any force generated from canalits collected in the semicircular canal is greatly magnified at the cupula. We estimate this factor to be more than 15 times. But before the gravitating canalits can move the endolymph, they must overcome the inertia and resistance of the entire fluid loop, as well as the elasticity of the cupula. This typically takes several seconds and explains the period of latency before the onset of nystagmus. Finally, the endolymph begins to move and displace the cupula, generating torsional nystagmus with its fast phase directed opposite to endolymph flow. When the canalits reach the limit of their descent, the drag ceases, the cupula returns to its neutral position, and the nystagmus stops fairly abruptly. When the head is returned to the upright position, the canalits reverse direction and a reversal of the scenario takes place. Turbulence around the group of gravitating canalits causes them to disperse. So every time the maneuver is immediately repeated, canalits begin in a more dispersed state, which explains the decline in response. In summary, the canalithiasis scenario explains all characteristics of the typical nystagmus cited by Dix and Hallpike. In further support of Epley's canalithiasis theory, Parnes and McClure recently documented at surgery the presence of free dense particles in the posterior canal of patients with typical BPPV. This condition should be called by its pathological diagnosis, canalithiasis, rather than by its symptomatic diagnosis, benign paroxysmal positional vertigo. Patients seldom are able to provide a coherent description of their vertigo symptoms without assistance. An understanding of the canalithiasis theory provides great insight into taking and interpreting this history. For instance, a common complaint of the canalithiasis patient is that vertigo occurs shortly after lying down on a particular side. This is analogous to the scenario just described, which follows the Dix-Hallpike maneuver, including the period of latency. Dizziness upon arising is analogous to the return to upright portion of the scenario. The accumulated canalits gravitate toward the ampulla. Another common complaint is vertigo shortly after rolling over in bed. Before the roll, the posterior canal of the uppermost ear is in the earth horizontal plane. Rolling the head places that canal in the vertical plane, so that any collected canalits present can begin to gravitate and cause vertigo. Tilting the head forward as to pick something up results in movement of the canalits toward the ampulla. Sudden deceleration along the plane of the posterior canal, such as stopping a car while the head is turned, has the same effect as leaning forward. One or any combination of these different activities may be causing symptoms in the same patient. In severe cases of canalithiasis, dizziness may occur with any physical activity. The diagnosis of canalithiasis can be confirmed only by actually observing the typical nystagmus after positioning the patient. The Dix-Hallpike test is traditionally done from the front of the patient. However, Dr. Epley recommends an approach from behind the patient. The observer is looking directly into the eyes and can even be seated. Also, repositioning can be done from this approach. One hand cradles the head, while the other gently lifts the lid for a better view of the eyeball. Remember, the objective is to place the posterior canal in the vertical plane, so the head is turned only 45 degrees to the side. This also neutralizes any canalits present in the contralateral posterior canal by virtue of its more horizontal placement. If instead the head is turned 90 degrees, canalits in the contralateral canal can generate nystagmus, giving a false impression as to the side with the pathology. This can lead to a misdiagnosis of bilateral canalithiasis. Because the nystagmus of canalithiasis is so severe, it is not suppressed by visual fixation, so it can easily be viewed directly. And Frenzo glasses are usually not needed. But infrared video, such as this system from iDynamics, can be very useful, giving a high magnification, high definition image that can be videotaped. This will allow review of transitory but critical eye movements. A note of caution: tailor the diagnostic maneuvers to the particular patient. If their symptoms are severe, avoid nausea by using slower maneuvers. In patients with neck and back problems, the nystagmus of canalithiasis can still be elicited without extending the head. No other diagnostic tests are of any value in ruling canalithiasis in or out. By analyzing the nystagmus, we can not only confirm the diagnosis, but also can locate the site of the canalits and estimate their terminal velocity. Thus, a thorough understanding of nystagmus is imperative. Torsional nystagmus is usually generated by the posterior or anterior canals. Because these canals are angled laterally, they generate nystagmus with an offset axis. Nystagmus occurs in the plane of the semicircular canal which generates it. This plane remains fixed relative to the head, regardless of the gaze position of the pupil. This is the nystagmus generated by the left posterior canal. It is always torsional, with its axis offset to the left. Note that the direction and extent of the pupillary excursion will vary depending upon the position of gaze. Therefore, in observing nystagmus, ignore the pupil and follow the movement of the vessels on the eyeball, noting the orientation of its plane and axis of rotation. With torsional nystagmus, look for the point of minimum movement to find the axis. With the typical nystagmus seen in the Dix-Hallpike position, the axis is always offset laterally toward the undermost ear. This can be considered the sixth characteristic of typical nystagmus. This, plus the characteristics of latency, torsion beating toward the undermost ear, and limited duration, are pathognomonic. The other two factors cited by Dix and Hallpike, reversal and response decline, only help to confirm the diagnosis, and in fact may not be observed at all. The finding of typical nystagmus indicates that the pathology is in the posterior canal of the undermost ear. Dr. Epley's realization of the canalithiasis theory led him to the concept of canalith repositioning. He reasoned that if the particles are free in the canal, it should be possible to move them out of the canal and into the utricle, where they would lose their effectiveness in producing cupular deflection. To accomplish this, he devised a method of maneuvering the head so that the particles would migrate through gravitation. He later enhanced this with oscillation. Migration of particles through a curved tube can be accomplished by rotating it in the plane of gravity. The particles migrate in the opposite direction. But if the tube turns too fast, the particles will go over the top and start to migrate in the reverse direction. On the other hand, if it turns too slowly, some of the particles will adhere to the side walls and not migrate at all. So, for maximum effectiveness, the tube should be turned at the same rate as the particles descend, keeping them in a constant state of free fall. But how can we do this in the actual semicircular canal where we can't see the canalits? Fortunately, we can observe the nystagmus which the gravitating canalits induce. The nystagmus duration during the Dix-Hallpike test provides an estimate of the time period that the canalits are gravitating freely. Research indicates that particles will gravitate through approximately a 60-degree segment of a stationary curved tube. Thus, we can estimate the time it takes for the particles to migrate through 60 degrees of semicircular canal. So, if we allow that amount of time as we rotate the canal through 60-degree segments, we increase the chances of keeping the canalits gravitating freely all the way to the utricle. To rotate a posterior semicircular canal exactly in the plane of gravity through its 240-degree angulation would require a special apparatus which inverts the patient. But for the typical case, we can obtain reasonable success using maneuvers designed for a clinical table or chair. This simplified form of canalith repositioning is carried out as follows. The patient is maneuvered through a positioning sequence which rotates the target canal in increments of roughly 60 degrees while keeping it in the vertical plane. The maneuvers are also designed to avoid retrograde migration of the canalits. A timing strategy is used to keep the rotation rate at approximately the terminal velocity of the canalits. Thus, each position is held as long as the observed nystagmus continues, or for a length of time predetermined from the nystagmus duration in the Hallpike test. So, real-time monitoring of eye movement during the maneuvers is essential for determining ongoing strategy, which may change during the procedure. As with the Hallpike test, this nystagmus can be viewed directly. Two-channel ENG can also be helpful, particularly when the eyes are not easily observed. Infrared videography is ideal for both real-time monitoring and documentation. Laboratory experiments demonstrate that oscillation greatly reduces the tendency for the particles to adhere to the sidewalls and increases their tendency to tumble. Applying this to canalith repositioning, our studies have shown that oscillation contributes as much as an additional 20% to the success rate. A Swedish-type hand oscillator may be used with the vibrations transferred to the skull through the hand. Or the lead oscillator can be strapped onto the head, leaving the operator's hands free to maneuver the patient. Oscillation should be used judiciously if there is a question of retinal detachment, paralimb fistula, or irritative labyrinthosis. Now let's apply this to treatment of a patient. The target canal was indicated by the positive preliminary Dix-Hallpike test and was the posterior canal of the undermost ear. Also, the duration of the induced nystagmus was noted. This will be used as the time for change from one position to the next. Pre-medication to control anxiety and nausea, though not always needed, is generally recommended, with patients taking 5 milligrams of Valium orally 30 minutes before the procedure. An assistant is strongly recommended, situated on the side away from the target ear to help maneuver, steady, and reassure the patient. The operator stands directly behind the patient as described for the Epley approach. We will carry out maneuvers for a left posterior canalithiasis. The procedure begins with the patient in the sitting position. Envisioning the labyrinth from behind, the canaliths are in the most dependent portion of the left posterior canal. The first position is similar to a Dix-Hallpike maneuver to the side of the target canal. The canalits start gravitating through the canal. In each position, when the nystagmus slows, this indicates that the canalits are finishing their free fall, and the head is maneuvered to the next position. If no nystagmus is seen in any position, the predetermined time would be used for the next position. The head is now moved to the opposite Hallpike position, keeping it well extended in order to bring the canalits to near the apex of the posterior canal. If the canalits do not reach the apical area, they may migrate in the reverse direction during the next step. The head is further rotated to the 135-degree down position, rolling the patient onto their shoulder. The canalits moved to the common crus. Without turning the head forward, which would cause retrograde movement of the canalits, the patient is moved to the upright sitting position. Then the head is turned forward and tilted slightly downward so that the common crus is earth vertical. The particles should now pass into the utricle. The patient is now in position to repeat the cycle. The nystagmus observations in each position are documented. Complete cycles of this sequence are repeated until no nystagmus is observed during the last cycle or until no progress is apparent in the last 2 cycles. Unless contraindicated, oscillation is applied to the skull on the 2nd cycle or after the nystagmus intensity has been abated. It is continued throughout each cycle thereafter. The reason for delaying its use is to minimize nausea, since oscillation may increase the severity of the nystagmus. The positioning sequence for the right side is a mirror image of that for the left side. In summary, while undertaking the positioning sequence, the induced nystagmus is observed in order to track the direction and rate of canalith migration. A timing strategy is used accordingly. Oscillation is applied after the first positioning cycle or after the nystagmus is significantly decreased in intensity. After the session is finished, patients are advised to avoid head-down positions and to sleep on 2 pillows during the next 48 hours. This is to minimize any tendency of particles to gravitate back into the posterior canal. After that, patients may return to normal activity. Resolution of nystagmus immediately after canalith repositioning does not necessarily represent long-term success, because the canaliths may only be temporarily dispersed in the canal, so that they cannot act collectively to produce nystagmus. However, within a few days, they may recongregate and again produce nystagmus. This is why one should ideally wait a few days for a follow-up evaluation. The standard return visit is in 1 week, but shorter periods are allowed for out-of-town patients. On return, a Hallpike test is done. This is best integrated with the first position of another canalith repositioning procedure. Sometimes the patient will claim the symptoms are resolved, yet on the Hallpike test will still demonstrate nystagmus. This is because they are subconsciously avoiding the provocative positions. Canalith repositioning sessions are repeated at intervals until both the vertigo symptoms and Hallpike findings have been resolved. Thus, on each visit, if any nystagmus is noted, patients receive the full standard procedure, then are given another follow-up appointment. If nystagmus is not noted, they are given a booster using the oscillator for 1 cycle. This decreases the early recurrence rate, presumably by removing any residual asymptomatic canaliths in the semicircular canal. Then the patients are discharged. They are told that recurrences are possible and can be easily treated by the same method. Nausea may be minimized during canalit repositioning by controlling the production of nystagmus. In addition to delayed deployment of the oscillator, two other methods can be used. The first is the modification of Dr. John Lee of Palm Beach Gardens, Florida. He takes the patient gradually through the positioning sequence just under the threshold of nystagmus and vertigo production. The patient is instructed to report if vertigo occurs, and the rate of movement is slowed accordingly. After each cycle is completed, the results are evaluated with a Dix-Hallpike test. Because Dr. Lee's maneuvering is purposely done more slowly than terminal velocity, the canalits will tend to adhere to the sidewalls unless oscillation is used. Therefore, this method must be accompanied throughout by adequate oscillation. The downside of Dr. Lee's modification is that because nystagmus production is purposely avoided or minimized during the maneuver, consequently, a valuable source of information is lost regarding ongoing pathology. But one can get the best of both worlds by using Dr. Lee's modification only on the first cycle or two until the canalithiasis is at least partially cleared. Thereafter, positioning can be carried out according to the standard method. The other method for controlling nausea, often used by Dr. Epley, is to bring the head straight back to start the initial cycle, and then gradually turn the head toward position 1 to bring the target canal to the vertical plane. If nystagmus occurs, he immediately reverses the head turn, then tries again. About 1 in 50 cases of canalithiasis involves the horizontal canal as the site of pathology. This is typified by extremely severe vertigo. On Dix-Hallpike testing, the nystagmus is very rapid with a short latency. It is seldom purely horizontal, but more often follows a curvilinear pattern. The tip-off is that it is centered in the anterior-posterior plane. In contrast, posterior canal nystagmus is offset laterally. To identify the side of involvement, we wait till the nystagmus stops, then roll the head without extension to the other side and hold it there. A strong nystagmus will continue to beat for several seconds in that direction toward the undermost ear. This is due to the canalits gravitating after the head is rotated. The same will occur again in the opposite direction. In general, the nystagmus will beat faster toward the ear of the canalits because, according to Ewald's second law, response is greater in the horizontal canal when flow is toward the ampulla. Treatment follows the same principles as with the posterior type, but the positioning is different. Without extending the head, it is turned away from the involved ear, having the patient do a complete 360 barbecue style if they were agile enough. The patient then sits straight up. In the less agile patient, try to take them at least to the 135-degree down position. A 360 is more easily done with a positioning apparatus. Complications from canalit repositioning are rare. Neck and back injuries should not occur if the procedure is done gently. Avoid variations which involve violent maneuvers or radical deviations from standard procedure. Another problem seen on rare occasions during repositioning is the canalit jam. Here, after a change of position, severe nystagmus starts and will not stop, regardless of the head position. This is presumably due to the canalits jamming in the canal or lodging against the cupula. It occurs when the number of canalits is great. The patient may demonstrate severe anxiety, diaphoresis, and vomiting, so it is imperative to be prepared in advance. It helps if the patient has been pre-medicated. Canalit jam is treated by reversing through the positioning sequence with the oscillator applied in order to back the particles out of the jam. Occasionally, during repositioning, the canalits will divert to another canal. The nystagmus profile will change accordingly. If typical nystagmus converts to horizontal nystagmus, immediately change the positioning sequence to that for the ipsilateral horizontal canal. Successful resolution is indicated by a negative Hall-Pike test on the follow-up visit, as well as no further positional vertigo for 1 month. Using the methods described here, Dr. Epley and his Portland clinic have obtained resolution in over 95% of cases. About 80% of patients have been asymptomatic and free of induced nystagmus on the first follow-up visit. Other centers which have used Dr. Epley's protocol have reported comparable results. The Dix-Hall-Pike test should be performed on essentially every patient complaining of vertigo, including patients returning for follow-up with other proven diagnoses, because canalithiasis often occurs concomitant with other causes of vertigo, such as Meniere's disease, post-traumatic vertigo, or vestibular neuronitis. A negative Hall-Pike test does not rule out canalithiasis, and if symptoms persist, the test should be repeated on separate occasions. If the nystagmus and symptoms are cleared by repositioning, no further diagnostic workup is necessary. If the Dix-Hall-Pike test is positive bilaterally, treat the more severe side until it is resolved, then treat the other side if necessary. When canalithiasis is strongly suspected, but a positive Dix-Hall-Pike cannot be elicited, canalith repositioning with oscillation can be used as a therapeutic trial, as it may bring out latent positional nystagmus. Beware of atypical nystagmus. If the criteria of the typical nystagmus of canalithiasis are not met, or the vertigo symptoms are not quickly resolved by repositioning, then a more thorough workup is indicated. Typical nystagmus is pathognomonic for posterior canalithiasis and probably does not occur in response to any other pathology. But it may occur concomitant with other pathology in the ear or the central nervous system. The complex diagnostic picture thus presented may be quickly clarified by carrying out canalith repositioning. Recurrence of canalithiasis after months to years is not uncommon with any treatment method, but can simply be treated again by canalith repositioning. In rare instances, canalith repositioning is not successful, usually because of multiple recurrences. In those cases, surgical canal plugging is our treatment of choice. Some final points for preventing retrograde migration of the canalits during the maneuvers. This time, the target canal is the right posterior. The head is turned 45 degrees to the side of the target canal. The patient is then brought back so that the head is extended 20 degrees below the horizontal. This is position 1. Give the canalits time to gravitate. Hold until the nystagmus stops. While going to position 2, maintain this 20-degree extension. Do not raise the head up, because this will cause retrograde migration of the canalits. The head is turned to the opposite side, 45 degrees from center. This is position 2. The canalits move toward the apex of the canal. In going to position 3, the body must be rolled to that side. Do not allow the patient to straighten the head before rolling the body. This can cause the canalits to reverse direction. Instead, keep the head turned and roll onto the side so that it is facing 135 degrees down for position 3. The canalits gravitate toward the common crus. At this point, advise patients not to straighten the head as they sit up, as this can cause retrograde migration. Instead, the head is kept turned as far to the same side as possible until the patient is sitting up. Then straighten the head and immediately tilt it forward 30 degrees. This orients the common crus vertically and allows the canalits to pass into the utricle. All nystagmus during the foregoing sequence should be in the same direction. Nystagmus in the reverse direction indicates reverse migration. This means that the maneuvers were not done properly. We will now demonstrate the mirror image sequence for canalits in the left posterior canal. The head is turned 45 degrees to the side of the target canal. The patient is then brought back so that the head is extended 20 degrees below the horizontal. This is position 1. Give the canalits time to gravitate. Hold until the nystagmus stops. While going to position 2, maintain this 20-degree extension. Do not raise the head up, because this will cause retrograde migration of the canalits. The head is turned to the opposite side, 45 degrees from center. This is position 2. The canalits moved toward the apex of the canal. In going to position 3, the body must be rolled to that side. Do not allow the patient to straighten the head before rolling the body. This can cause the canalits to reverse direction. Instead, keep the head turned and roll onto the side so that it is facing 135 degrees down for position 3. The canalits gravitate toward the common crus. At this point, advise patients not to straighten the head as they sit up, as this can cause retrograde migration. Instead, the head is kept turned as far to the same side as possible until the patient is sitting up. Then straighten the head and immediately tilt it forward 30 degrees. This orients the common crus vertically and allows the canalits to pass into the utricle. All nystagmus during the foregoing sequence should be in the same direction. Nystagmus in the reverse direction indicates reverse migration. This means the maneuvers were not done properly.
Canalit repositioning offers the most effective and tolerable treatment of BPPV. If properly undertaken, one should obtain a resolution rate of better than 90%. Thus, it should be the treatment of choice.